Class is now starting. All attendees are in listen-only mode.
Good day, everyone. Thank you for joining us today for our webinar, Maximizing the Value of Your Nursing Technology Fund Application. Before we get started, I would like to go over a few items so you know how to participate in today's event. At the top right of your computer display, you should find the GoToWebinar attendee interface, and through this you can interact with the session today. You may have joined conference audio using your computer speakers by default. This means if you can typically hear music through your computer, you should be able to hear the presentation now. If you prefer to join conference audio via telephone, please click telephone in the audio portion of the panel and the dial-in information will be displayed. You will have the opportunity to submit questions and comments to today's presenters by typing to the questions portion of this control panel. Please submit your questions and comments anytime during the presentation. We will collect these and address them during a Q&A session at the end of the presentation. Now, to begin the webinar, I would like to turn things over to Colin Truesdale. Colin?
Hi Josh, thank you very much. Thank you everybody for joining us this afternoon. So today we're going to look at the Nursing Technology Fund, how we can apply, how to do good applications, and how we can actually make technology really help your nursing teams in a practical way. So just by way of introduction, so my name is Colin Truesdale. I'm a Senior Consultant with Kainos Evolve, and joining me is John Damman from Channel 3 Consulting, and he's going to be going over the practicalities of presenting your application. Good afternoon, John.
Good afternoon, Colin. Good afternoon, everyone.
And as Joshua said, from a practical perspective, you can ask questions at any time, and we will address those at the end of the webinar, and you can ask those via the question and answer button on your webinar toolbar. So without further ado, I'm going to hand over to John, and he's going to go over how you apply for the Technology Fund, what it is, etc. John.
Thank you, Colin. In this session, I'm going to outline the criteria for applying for nursing technology funds. First of all, I will briefly summarise the first fund, as there is a definite synergy between the two. So in terms of background, the first fund was referred to as the Safer Hospitals, Safer Wards Fund. It was announced in May by Jeremy Hunt, the Secretary of State, and Professor Sir Bruce Keogh, the Medical Director of NHS England. Expressions of interest were invited during a one-month period in the summer, throughout the month of July, and it was designed to support the move from paper-heavy systems through to paper-light, and from paper-light to paperless. This, of course, is entirely consistent with the NHS central initiative to have digital care records in place by 2015 and for the NHS to be entirely paperless by 2018. The fund itself was primarily aimed at integrated digital care records and e-prescribing, though we did see a very wide range of variants, which included EDM, maternity, electronic handover, and infection control, amongst many others. In terms of the process, £260 million was announced, and expressions of interest were invited across the 2-year period covered by the £260 million. This is a different process to the process which is now being advocated in relation to the nursing fund, where only the first tranche of funding is biddable, and I'll say more about that in due course. There was no maximum bid value to the first fund. There was no limit to the number of applications. There was a stipulation that the trust must match the value of the funding requested from its own funds. The funds that were granted must be spent before the end of the bidding period, which is March 2015. Assessments were planned for September. There was a slight delay, but most of the assessments got off the ground by the end of September. They said at the time that announcements would be made in October. This was delayed, as we've now know, due to the need for Treasury approval. After the expression of interest period, it became quickly obvious that the funds were very heavily oversubscribed. There was something like 760 expressions of interest, and this amounted to £650 million worth of funding. So that the fund itself was 2.5 times oversubscribed. Despite this, £50 million plus has been held back by NHS England and not been allocated, and we've heard since the announcement that this will be rolled into the Tech Fund 2, which will be announced sometime after Christmas, making that fund equal to approximately £300 million. Channel 3 managed expressions of interest for a good many trusts in the first process, some 25 trust submissions. The evaluation process did commence, as I said, in late September. The assessment interviews took the form mainly of a conference call or meetings held either in Leeds or London. Exceptionally, there were some meetings that were held on trust premises. There was always an expectation after this assessment period that the normal trust due diligence process would be expected. What that means is that for an investment of this size, outline business cases are required. Okay, so that brings us more or less up to date. The Nursing Fund was launched a week last Monday on the 9th of December, and it is aimed at taking away some of the administration from nurses to enable them to spend more time directly with patients. The fund is valued at £100 million, but at this stage the NHS England are inviting bids against the £30 million fund, which needs to be spent by the end of March 13-14, which means we have a 3-month period both to apply for the funding and subsequently to spend the money, which means that the project should complete by the end of March, which may be a tall order for some hospital trusts. It's worth mentioning at this point that there was a rumour in the run-up to the announcement that the loan would be written down subject to trust providers realising the benefits set out in the application process and subject to a positive friends and family test. This has not been referred to in the guidance documentation, certainly that I've seen. That's not to say that the PDC grant won't be written down in due course, it's just that they haven't communicated the fact yet. The funding will be available for, these are the examples quoted by NHS England, digital pens, notebooks, tablets, mobile technology, monitoring and telehealth, and they specifically talk about ward systems and mention vital signs. They also say that funding is available for essential clinical information to enable uploads to digital care records. In terms of the background, there is available on the NHS England website a series of documents. The first is a prospectus which gives details of the programme. It talks about eligibility and the application process itself. There is then some further guidance in the form of some more detailed application instructions. There is some VFM guidance as well, and this is particularly important. It sets out what should be included in the costs. It mentions that the 2013-14 pay and price levels should be used. It talks about the discount rate. The discount factor that must be used is 3.5%. And crucially, it sets out the basis of for the quantification of benefits, both quantitative and qualitative. It also sets out that the cost to benefit ratio should be 2.4 to 1, which is significantly higher than the cost to benefit ratio that was stipulated for the first technology fund. There is then on the website some application forms, 3 in fact. There is the main general application form that needs to be completed. There's a financial analysis template and the crucial VFM analysis template as well. In addition to that, they are stating that a technology diagram is required for each project. The assessment process, we are told, will follow a 3-stage process. There will be an initial screening criteria, and this assesses simply the organisational eligibility in the first instance. That means the fund is open to hospital providers, that includes mental illness and acute, and community, and ambulance services as well. It is not applicable for charities, commercial organisations and networks, and social enterprises as well. So the test, the initial test will assess that. There needs to be a commitment as well to spend the funds before the end of March. That needs to be very clear. And the criteria will also cover the fact that the solution meets the general funding requirements set out in the briefing documentation. If the application is successful, it then moves on to the technical assessment, and this is then followed by a clinical evaluation. So the clinical evaluation is being conducted by the regional area teams and the chief nurse from the local CCGs. What it is intended to do, can we just hold for a second? We're having some technical difficulties.
Sorry, we're aware that there's a lot of crackle, so I'm just going to swap and give John my headset.
Okay, hopefully you can hear me now. It's much clearer from my perspective. What I was saying was that there will be a clinical evaluation, and this will be run by the regional area teams. And also involved will be the chief nurses from local CCGs. This is intended to test certain characteristics which are clearly outlined on the NHS England website. These are that there must be a high prospect of patient and clinical benefits, there needs to be a strong nursing ownership, a significant VFM ratio, as I say, in excess of 2.4 to 1. That means for every pound spent there must be benefits returned of £2.40. There needs to be local finance engagement and finance director approval, very strong alignment with trust strategies and national strategies as well. Credible sourcing approach that can deliver rapidly, this is essential. They're looking for strong project management. They're also specifically referring to having previous experience of clinical process redesign and change. Now, where this is not evident in the application process, hospital providers need to make sure that they partner with organisations that have the suitable process redesign expertise. The evaluation team are also looking for experience and capability to develop, deploy, train staff and support the proposed technical solution. Now, when the application succeeds through to the clinical evaluation stage, the final hurdle to negotiate is that the Trust must also sign a Memorandum of Understanding. The MOU places obligations on the Trust, and it stipulates that they should take part in sharing learning with the rest of the NHS. Okay, so again, the NHS England website has some pointers for success. It says that the projects must have a degree of momentum to enable the application to be evidenced in a quality way by the 15th of January. The funds must be spent in their entirety by the 31st of March 2014. That's just 3 months. And the clinical business process change needs to be in step with the technology deployment. The benefits to be must be realised then in a reasonable time after the project has completed. There needs to be evidence of nursing leadership, of Director of Finance approval, and a credible sourcing approach that will deliver rapidly. Existing project management and benefits tracking must also be in evidence. And looking back to the first technology fund, the assessors were particularly pleased when there were executive directors and senior clinicians involved in the process, and this signifies to the centre that the trust concerned is not simply making a speculative bid against the funds. The practical advice from me, and this is at the risk of sounding like the school headmaster, the first thing is to make sure that you learn the rules. Read the questions on the website. You would be surprised how many trusts that Channel 3 supported in the first instance did not do that. Multiple projects are allowed, but they must be supported by multiple expressions of interest. You need to make sure that your implementation plans do not exceed the deadlines stipulated by NHS England. You need to avoid vague, unrealistic or naive answers, and particularly avoid overly technical responses. That you need to link the projects to strategies, both from an organisational perspective, clinical strategies and the trust business strategy, and NHS policy as well, and I'm thinking particularly there of complying with the requirements arising from the Francis report and the paperless initiative in particular. You need to make sure that you engage finance support in good time. There is quite a lot of input here for a finance department, and there is an appreciative amount of detail required. You need to carefully quantify credible benefits. This is something that can take quite a lot of time. The benefits need to be quantifiable, and don't forget the rumour. As we talked about previously, it is likely, certainly possible, that the centre will write off the loan subject to achievement of the benefits, and if they do agree to do that, you need to make sure that the benefits are really achievable. Clinical process change is key to achieving the benefits in my experience. If you don't have a track record of working through process change, you need to seek external advice. Now, I'm going to finish my session now by just giving you some key dates. So just to recap, the 2013-14 tranche of the £100 million, which is valued at £30 million, expressions of interest have to be with NHS England by midday, actually, on the 15th of January. We're told that successful applicants will be notified by mid-February. They will then need to sign a memorandum of understanding before the end of February, and the funds must be spent by the 31st of March. For the 2014-15 tranche, that is the remainder £70 million, what the NHS England are asking trusts to do is submit a very simple submission by the 26th of February, and that will simply say what the solution is that is being considered, who is it going to be deployed to, and in what numbers. But they also want to know your experience of the solution and any key challenges from your perspective. Okay, so at that point I'm going to hand back to Colin.
Thank you, John. Sometimes just passing a headset and doing it the low-tech way is better to avoid the crackle. So what we're going to do now is we're going to look at, well, now that we know what the nursing fund is and how it works, what are the ways that you can actually see benefits from a technology perspective? What technology sets are out there that can really help you and your nursing teams bring better quality care, more efficient care, etc. And so in our reading of the Nursing Technology Fund, the main themes that we saw were, okay, access at the point of care, so be that at the bedside, be that in the patient's home. The ability to increase the number of patients as well, so actually reducing the amount of time that nurses spend traveling if they're out in the community, enabling them obviously to spend more time with the patient. Help to reduce the incessant repeating of collection of the same data over and over again, so much better data reuse. And then also obviously releasing time back to care by reducing waiting time, bringing down waiting lists, etc. And so in Evolve we have two main ways of doing this. So for Evolve for ward-based nursing teams and also Evolve for field-based nursing teams. And so the technology solutions that we would provide would be the ability to capture vital signs at the bedside. So no longer having a whole stack of notes at the bedside, being able to do it all electronically via a ward PC or a mobile device like an iPad. The ability to have ward quality audits, so being able to say, okay, how are our wards actually performing? Are we meeting targets for care? Are we meeting targets for VTE assessments being carried out at the right point in time? The ability to help nursing teams proactively manage the care pathway, saying, okay, at this stage in the patient's care, you need to be doing this. This is the data that you need to be capturing. These are the steps that you need to be performing. Being able to accurately and quickly exchange information between care providers so that we're all on the same page. There's no room for clinical risk through miscommunication. Also then, the very fact that we're able to capture information electronically means that we can easily reuse it. If we want to do a clinical audit, the information is there at our fingertips to report on. Also, because we're capturing everything electronically, we can then set up verification to say, well, okay, look, it looks like the blood pressure values that you're capturing here are incorrect because they're outside a certain range, etc. The ability for a nurse on a ward, maybe your Wi-Fi connectivity is spotty throughout the hospital, well, the ability to actually take patient information offline on a device like an iPad means that you can help avoid those black spot issues, that you've got continuity of information and continuity of care based upon that information. And also the fact that a solution like Evolve in particular, easily integrates in with your EPR solution. So where you're using an EPR to manage ward lists, clinic lists, all of that information can flow down to Evolve. Where you're capturing information in your EPR, it can then flow to Evolve. Any information that you capture in Evolve can flow back to the EPR. Again, making sure that people, systems and processes are all connected up. And through all of the above and through the efficiencies that they bring, we see that we can help you to provide an additional hour per day per nurse to deliver care. So that's time that would otherwise have been spent in administration and re-entering of data. That can then be made more efficient and funneled back into the care process and providing better care for your patients. For field-based nursing teams, so we have full HL7 integrations. So for example, my wife's a community physio, so the idea is that before she leaves the house in the morning, she'll be able to open her device. She'll see a list of patients that she's seeing that day, and that will have been powered by an HL7 feed coming in from the EPR from the Trust PAS. She will then be able to synchronize offline all of the patient information that she needs for her day, so all of the patient case notes. While she's in the patient's home, it's obviously at her fingertips. She's not reliant on a connection or on spotty and poor 3G access. She can fill in any forms in the patient's house and have those synchronized back to base. She can do this via an iPad. iPads are generally loved because they're so easy to use. They're very intuitive, they're very light and easy to carry about. She'll have access to the information from previous episodes of care so that she knows exactly what's going on. And one of the main areas of miscommunication is always handover. So here we've got one source of truth that's shared between multiple parties. We've got better information. We can also then be able to advise the patient better, and that will again also obviously lead to less readmissions and less spurious readmissions because we're not sure what's going on with this patient. And again, it's easily integrated into your strategic EPR, having that information flow down from the EPR to Evolve and back up again. And using a technology set for field-based nursing teams, we would estimate that Evolve can help you to provide additional 1 or 2 additional visits per nurse per day. So again, more efficient care and better care, more time spent with the patients. So let's look at the technology set that actually enables all this to happen. And I would just also remind you that you can submit questions at any time using your question panel, and we will deal with those and come to those at the end. So the first one is get your people out and about on the wards, out and about in the community, using mobility solutions such as Evolve for iPad. And when Jeremy Hunt first came out with his paperless ambitions, there were a few studies done, and one of which was the digital first strategy. And the digital first strategy made the claim that £36 million could be released across the NHS just by using mobile solutions. So that works out an average of around £3,000 per community nurse. And it enables them to spend 14% more time with the patient because they're not having to run back to base to get more notes. They're able to see 17% more patients per day. And because they've got better information at their fingertips, they're able to make better informed decisions. They're not saying, I'm not sure what's going on, I'm going to have you admitted. It reduces the admission volume as well. So better care for the patients, more efficient care, also keeping them out of hospital, which is obviously what the patient would prefer, to be treated in the home without a spurious admission to the hospital. The digital first strategy also made quite a bold anecdotal claim, and it said that Tower Hamlets Primary Care Trust anecdotally recognized the fact, or thought that they would be able to save enough so that within the first 2 weeks of going live they would have met their spend for the project in terms of devices, in terms of management software, etc. So you can see that organizations reckon there's a massive opportunity by empowering their workforce to deliver mobile-based care and mobile-based information. There's massive savings and massive in terms of efficiency and increasingly quality of care delivered to patients. A very bold claim, and we'll see what happens in the wash. So in terms of technology sets, Evolve has a native application for the iPad. It allows you to view records, to find patients, it allows you to complete electronic forms. And we've done a lot of studying, and we have targeted at people who are on wards, people who are out in the community, and people who are running outpatient clinics. And so for example here on the left hand side I'm saying show me everybody that's attending the Diabetes Main Hospital Clinic, or who are currently on the Haven ward. So we can see there the clinic, the ward, and it then brings me back a list of patients, and this list of patients is driven by the HL7 messaging that's coming in from the PAS. So it's again a joined up system. Selecting a patient then shows their items, shows their documentation, etc. And again, nice and easy to use. We've got thumbnails, we have the ability to flick through pages. It's a very familiar way of working, a very streamlined way of working. So I've now got full access to the information for this patient, whether I'm online or whether I'm offline through synchronization. I've also got the ability to fill in forms at the bedside or wherever I happen to be in the patient's home, etc. So again, it's a real empowerment of the user base to capture better information and to have better information available wherever they are to make better informed decisions. A lot of this is powered by electronic forms and workflow. And from our perspective, the main benefits of electronic forms and workflow are you capture information once and you can then pass it downstream to other systems. You can also pass it downstream to other organizations as well. So much better availability of information for reuse. You can also start building processes and workflows and pathways. So for example, Jane Smith was admitted. We know that because we've had an admission message come in from the PAS. She was admitted 8 hours ago, but nobody has carried out a VTE assessment, or it's been 3 hours since she had her vital signs taken. So that can then remind the nursing team to take the appropriate action at the appropriate point in time of care for that patient. If they don't do that, if they're maybe going to miss a target, that can then be escalated automatically to maybe the nursing care coordinator, director of nursing, etc. to say, look, there are items that aren't being taken care of. Because we're completing information electronically, it's going to be in a consistent format. You can have ranges, etc. So the information is now being captured in a much more structured way. It allows us to do better reporting, better analysis. And again, that idea of helping to drive patient pathways via the workflows. So for example, here within the core desktop Evolve, I can say I'd like to fill in an electronic form. It's an assessment form, in particular a VTE, risk assessment form, and the appropriate form is then shown to me on screen, ready to go. I can then fill it in, and again, it's all very structured information. We can then push that into a database, pass it on to the appropriate organizations, maybe the appropriate parts of my own organization, and report on it to say how many of these were being captured at the right point in time. So this leads me on to talk about auditing, talk about quality. So Evolve includes a quality management system, and the quality management system essentially allows us to capture ward level activity, ward level audits. So for example, how many VTE assessments are you carrying out? Are you hitting 95%, 98% of your targets? Or for a given ward, what's the status and the treatment status of that ward? How many patients actually have a UTI? How many end up with a pressure ulcer on that ward? So keeping track of what's going on. What we don't want is for this to actually generate more paperwork. So we want this to be rolled up into a report automatically so that we can see at a high level exactly what's going on in that ward. But we can do this by capturing information that is already being captured. So the nurses, as they capture the VTEs into the electronic VTE assessments, that can be feeding the QMS system. So there's no additional work here to be done, and there's no additional overhead for the frontline staff. So for example here, I can say, yes, I would like to bring up the Lavenham ward. I'd like to fill in a form. Specifically, it's a patient ward audit, and it then brings me up a form where I can go down through and say, yes, this patient has a pressure ulcer, this patient has or is being treated for DVT or a PE, these patients have a UTI. So again, this can be specific audits for a ward, so an action that somebody's actually going onto a ward and actually doing this audit, or it could be being gathered in the background by the simple fact that the appropriate forms are being filled in at the right point in time. And again, sort of staying out of the nurse's road, but giving that crucial information that allows us to properly manage the service and check for efficiencies and check that benefits are being captured and measured. Another way that we can help nursing teams is through Patient Manager. And this is really the who, what, and where of Evolve. So with Patient Manager, we have a standard lists feature where we can say, well, okay, show me all patients attending a certain clinic, show me all patients on a certain ward. And we've extended this to show then the status of the patients and to alert the nursing team as to what steps are required next in the treatment of that patient. And it's designed to really be a streamlined interface because we recognize that nurses are under a lot of pressure. They're very busy people. So we want them to be able to see at a glance exactly what's happening on their ward, who needs what done, what handover is happening, who needs a VT assessment carried out. And again, that's information that we potentially already have. So if you fill in a VTE form, then we'll clear that status off the patient manager screen. If they've been admitted, there'll be a standard set of steps that you need to take. We'll alert you to that fact as soon as we get the admission message in from the PAS. So it is largely driven from all of your other systems, but the idea is we're trying to knit that all together, provide one interface so we can see exactly what's happening and what needs to happen. So for example here, I can see my list of patients. I can also see the fact that Carolina needs a VTE assessment, that her medications haven't been prescribed at this point, etc. I can choose to just subscribe, so I'm only interested in handover at the minute, so just subscribe to handover messages. And I can put it into a bigger view to get a more detailed view. And so the fact that she still hasn't had that VT assessment, if I click on that link, it will then take me to the appropriate form for me to fill in electronically. If there are any actions that need to be taken, for example, she needs prophylaxis, it can send a message to the appropriate people saying this is what needs to happen next with the care of this patient. So it all comes down to good information capture that we can reuse for the treatment of that patient, that we can reuse to figure out what's going on our wards, and then driving the status of the patient from that information scattered from our forms, from the PAS, from other systems, for example. And then electronic discharge. So basically making sure that everybody is on the same page as to the status of this patient when it comes to the point of discharge. And the digital first strategy did make some mention of electronic discharge information and letters. And what they said was, well, currently in a paper-based world it costs around £2, actually slightly more than £2 per letter in terms of the time to create that information, to print it out, to post it and all the rest of it. And there are nearly 80 million secondary care inpatient and outpatient events that actually require one of these letters, so a heck of a lot of paper floating around the country. And what they saw was that actually if you went to an electronic form of working, you can reduce that £2.30 actually down to about 50p in terms of time and materials for the creation of that letter, leading to a potential saving and a potential efficiency across the NHS of around 137 million. And that doesn't even include the far end, the receiving end, them having to scan it into their particular GP system and all the rest of it. If we can achieve direct sending into the GP system, you know, the benefits are even more than that. There was a PricewaterhouseCoopers survey or a report done, and it was all about, you know, the sharing of information between primary and secondary care. Better sharing of information so that the right people know exactly what's happening, the GP knows exactly what's happening, what medications have been prescribed, what diagnoses, what treatments, etc., will lead to a reduction in spurious follow-up appointments. And again, leading to around £240 million of savings. So there are significant benefits to be gained from using technology in an innovative way like this. So the Evolve electronic discharge, so we have a collaborative form. So the idea is as soon as the patient is admitted, a form is created for the various care providers, so the dietitians, the nursing staff, physiotherapists, clinicians, etc., all to be dipping into this form as the treatment progresses for this patient. So they're capturing diagnosis, treatments, any comorbidities, any drugs administered. And the idea is, as I've said before, capture it once, reuse it multiple places. So sending that out to the GP automatically, helping to reduce paperwork, and this helps you to meet increasingly stringent targets. So for example, actually, in Ipswich they had a target of how many inpatient summaries need to be sent to the GP within one working day. And as of April 2011, that target was 85%, May it was going up to 90, etc. And there was a £75 penalty for every time that they missed that target. And what they reckoned was that from the 1st of April, that was going to cost them in terms of penalties around £33,000 per week of missed penalties. But with Evolve electronic discharge, as of July 2012, 94% of those inpatient discharges were sent within one working day. So that's over a year ago, so that figure is actually a lot higher now. And it's been a real success story for them. They've helped to mitigate against penalties, so they're avoiding those penalties. The GPs are much happier because they're getting information at the right point in time. We're able to flow that information down onto the community so that the right people are involved in the right care. The community care workers are getting the right information as to what's been happening with that patient in hospital so that they're providing the right treatment. So it's a win-win story really for everybody. And again, it starts with good information capturing and good information sharing, but largely making it easy for the nursing staff and for the clinical staff to capture that information in the first place. So let's wrap it up. So if we look at those main themes again and how we are using technology to meet those. So access to the point of care, yeah, on the wards and in the community, it's using a mobility solution like Evolve for iPad really helps to give you great access to the information that you already have and also an easy way to capture information going forward. The second theme was increasing the number of patients seen at the bedside or in their own home. Again, mobility helps there. E-forms and workflow also help in terms of making information capture more efficient. So my wife, for example, then when she has everything loaded on her iPad, wouldn't need to go to base to get more patient records during the day and to drop off forms, etc., which means that she's spending less time traveling, she's spending more time with the patients. We're reducing the idea of capturing the same information again and again. So capture it once, flow it down to other systems. So use forms and workflow, use the quality management system for wards so that we know exactly what's happening with our wards. Electronic discharge to automatically push that information out to other parties. And again, streamlining the care process by eliminating non-value adding steps. As part of this, what you would do is you would do a process where you look at your as-is processes essentially, and then how you want those processes to look, your to-bes, and you start mapping those into electronic workflows. So saying, look, here's the real-world process, here's how the technology can help support that. At this point in the care, we need to be capturing this information. So it's using workflow, using Evolve Patient Manager to get a high-level view of that very quickly as to what's going on with those patients. And again, obviously, all of this then leads to us being able to reduce waiting time to release time back to care by more efficient ways of working. So what are the next steps? Well, we can actually assist you with your application fund for both of the tranches, so for that initial 30 million spend before this March, and also the expression of interest for the further 70 million pot. Oh, and that's the 26th of February, I just had it whispered in my ear, thank you, John. We can arrange demos of the solution to your teams across the board, so that could be your clinical teams, nursing teams, it could be your IT people, your records people, your finance people. We're very comfortable talking at all those different levels. We can also provide you a sample EDM document management and medical records specification to help you to guide and speed up your procurement so you know what question to actually ask the supplier, because a lot of the time it's just where do we even begin with this, and we can certainly help you with that. And Kainos Evolve, we have a flexible licensing model and we have several different procurement routes available, so whether you want to go for a capital or operational expenditure model, we exist in several government procurements to help you speed up that application process or that tendering process, or if you're an existing customer you can issue a contract change notification as well.
Okay, just to finish off then, Channel 3 are an independent management consultancy. We only work in the health and social care sector, and we can and have in the past helped health providers navigate the technology fund process, and we would be happy to help you in the same way. At the end of this presentation there will be on the screen some contact details for how to contact both Channel 3 and Kainos. Okay, so we can provide not just support for the technology fund process, we can provide an end-to-end project support, and what we like to do is work in partnership with trust organisations to help from the expression of interest stage right through to the application, assessment and implementation subsequently, crucially realising the benefits afterwards, which is a key part of this whole process, is a particular specialist area of Channel 3. Okay, so for more information please contact me. My contact details are included on this final screen. Okay, so we're now into taking questions from attendees. I have one asking what are the key challenges from our perspective. Maybe if I answer that one, Colin. Clearly this is going to vary from one project to another, but in general quantifying the benefits and of course driving them out has to be a key area of challenge. A second challenge is around making sure locally that you have adequate finance support. Again, this links with the last point on driving out the benefits, because there's a clear financial dimension to that. You need to allow time as well, and there isn't a great deal of it, for both the benefits and the risk analysis as well. Some careful thought needs to be given to the risks, because this is part of the process of conveying to NHS England that you understand all the ins and outs of the project for which you're applying for funding for. The approach to measuring benefits is set out on the VFM template, but just to reiterate something that I said earlier, you do need to make sure that the benefits are achievable, and you need to achieve the 2.4 to 1 cost to benefit ratio at least. Okay, I hope that answers the question. We have another one coming in asking, how do we address the business change issue? This is about optimizing the care process that the technology is designed to support, clearly, so that the technology is used to maximum effect and benefit for the trust. In very simple terms, what Channel 3 would do is measure the current process, we assess the future state, and then we work with the trust very closely with clinicians to optimize the workflow. Channel 3 have worked with a number of trusts, particularly on mobile working projects and on clinical systems such as electronic patient records, maternity, theatres, various other projects, and actually some projects completely unrelated to technology. We have a division within the company who are exclusively focused on the issues around business change, so we're happy to help you with that.
Just a final couple of questions then that have come in, largely focused around the security of the devices and the use of iPad, etc. So actually we did a lot of work with Connecting for Health back at the start to identify what is the best platform for secure offline access to mobile records, and at that time, and actually as is still the case, that is the iPad. So we have built a native application that we have very heavily secured, so everything that you add to the iPad is encrypted by our application. It's also encrypted by the device. You must have a trust login. To be able to activate it in the first place, you'll have to put in a PIN into the device and a PIN into the application. So it's secured to the teeth, as it were, in terms of making sure that that information is very, very tightly controlled. As such, if you wanted to use a different mobile device, and as the BBC would say, other devices are available, so Android, Windows, etc., you could just use the direct connection to the web-based version, so not an offline application. However, if you want offline access, the iPad is how we would do that at present. Final question that came in, can you please email us the slides after the webinar? Absolutely. We actually have been recording this session, so you'll have not only the slides but our dulcet tones, and we will have an email sent out to you with that information in it. So that's pretty much us for today. Thank you very, very much for attending. All that remains for me to say is to thank John for joining us and for giving us his advice and wisdom, and really at this point of the year to wish you all a very happy and peaceful Christmas and New Year. Thanks, everybody.